Good morning.
Morning.
Okay, just, give it a moment and then we'll get going. Everybody have nice Thanksgiving plans this year?
I'm on call.
Okay, well, that's the best plan because you're helping humanity, Sergey. Okay, I guess we'll get going. Go from there. It's a short one today. Okay, so this is a tracing from a patient who had transposition VSD repair. And this is the 12-lead electrocardiogram that was obtained after surgery. And the fellow texted this to me, post-op ECG, sinus rhythm. I think the new incomplete right bundle with new incomplete right bundle branch block, confirmed QTC was 482. So what do we make of this? Do you agree with this? Do you have any concerns about this QTC, about the bundle branch? Why don't we go to Molly? Molly, why does this, do you agree with your co-fellow's comments on this electrocardiogram?
Good morning. Let me see here. I agree with the sinus portion.
Okay.
And then
And you're basing that on the fact that there's a P wave before every QRS. P wave is upright and leads 1.5. That's a normal axis. Okay, I agree with that. All of those statements.
And then in terms of looking at the bundle branch, incomplete portion, I would say yes.
Yeah, I agree with that. Why do you think this patient has an incomplete right bundle? Can you come up with a theory for that? I will just tell you pre-op there was not.
Yeah, because of the VSD repair, most likely. So
That's
there's
right.
delayed conduction from the repair.
That's correct. There can be sometimes some injury to the branch as a result of that. Okay.
And then in terms of the QTC, it definitely looks, on just glancing at it, it definitely looks a little long. And what I'm using to judge that is just looking at how the QT compares to the RR to interval, and it looks like it is over half. I actually need to count out the boxes here to see what I get on calculation of it.
So I agree with you, and I think that the fellow's calculation is not wrong.
Okay.
I guess the question is it important?
I mean, I think yes, in terms of thinking about like if it was more long than that, let's say if they calculated it and it was in the 500s or something, it could, if this person were to need antiarrhythmic treatment or something, it could sway your decision making. If the QTC was longer than it is, this is, I would say, mildly prolonged. So I don't know that it would change, like be as heavy weighing, I guess, if it was longer when we had calculated it.
Do you have any theories on why the QTC is a little bit longer than average on this patient?
It can also be with your your prolonged conduction, the incomplete bundle branch as well.
That's exactly right. And that's the point I'm trying to make, is that if you have an incomplete bundle or a complete bundle, and this is almost a complete bundle, then you can have then your QT may be prolonged because remember the QRS duration goes into the QTC calculation. Almost everybody who has a complete right bundle will have a QTC that is prolonged. This is why some electrophysiologists and cardiologists will measure the so-called JTC from the end of the QRS to the end of the T wave in order to measure a QT interval. Okay, so I guess what I would say to you is I don't know that was a critically important observation to make by the fellow telling me this. It's good that they're looking at it, of course, but I don't know that it's definitively critical to have that on there as well. Okay, so yeah, so that's why. Okay, so later that evening, the patient had this rhythm, and I was given a call. So I'm going to ask Tarek Zawani. Tarek, what do you think is going on here? And this is just a 12 lead again of the same patient, actually.
Hi, Dr. Brass. So I think looking at lead 1, 2, and AVF, I can't see any P waves preceding any QRSs. So and then the QRS is narrow. Looks
well. Let me just one more time. I'm going to show you. This is the same patient. This is the patient. We've already stated this is sinus rhythm, and this is the rhythm later that evening.
So this rhythm, I don't think it looks sinus. So I think probably it's. I think it's junctional rhythm, and going by the rate. Let's see. So it's around like 107 or 110. So
yep.
So not accelerate. Yeah.
Can you tell me if there's any relationship between the QRSs and the P waves? I agree with you. This is junctional rhythm. There's no P wave preceding every QRS. Again, I'm going to show you once more. This is the patient's electrocardiogram in sinus rhythm. And this is the patient's in this rhythm. So again, I'll show you sinus rhythm.
Yeah. So I think the QRS are the same, but the QRSs are the same, and then there are like P waves after after each QRS.
I agree with that. So there's, I think if you look here in the inferior leads, you can see what looks like a small P wave after every QRS. Now, how could you confirm that, Tarek? You have a patient who is right after surgery, a couple of hours after open heart surgery. Could you confirm this rhythm in any fashion at the bedside?
Yeah, I think at the bedside, the first thing to do will be in atrial EKG.
Okay, all right, we have that technology. So here is, in fact, the A wire of that of this patient. So has this confirmed the diagnosis that you just made, which was junctional with 1-to-1 retrograde P waves?
Yes, I believe so, because I think the atrial EKG was connected to the V1 and V2. Yeah.
Yes, so that's right. So so just remember, when you're looking at atrial electrograms, you know where the QRSs are. So V1 is a nice atrial electrogram. So the QRS is here. So anything that follows it is A wave. And, remember, because we're recording directly off the atrium, the atrial electrogram will be very large on the tracing. And so we have a V followed by an A in every case. Now, I would argue you don't really need this electrogram, because I do think that this tracing is extremely clear, but certainly may as well take advantage of all the little tools that we have at our disposal at the bedside. So the patient is now, let's make this up, 3 hours post-op, has a heart rate of about 107, and the blood pressure is a little bit soft. Maybe I'll make a number up, 54/35 in a newborn. So what could you do from a rhythm perspective, Tarek, to help this patient?
Yeah, I think one straight option would be to pace the patient, atrially pace the patient with the higher heart rate, and then to try to augment the blood pressure.
Yeah, and that's in fact exactly what the astute cardiology fellow did. They A-paced the patient, I believe, at about 140 or 145, and the child was stable for many hours. And then at about 2 or 3 in the morning, I was asked to assess this electrocardiogram on the same patient. So let me move on to let me go back to Dr. Bebia. So Sergey, this was the very calm tracing a couple of hours earlier. And we've been A-pacing at 145, and I was told that all of a sudden the heart rate got faster. So this is a 12 lead of that patient. What do you think is potentially going on here?
Well, let's see.
Aside from the very nice manicure of the person holding the electrocardiograms.
Yes, I noticed that.
It's very nice. Have to get that person's name.
Yeah, I think that this could be atrial flutter probably, because I might see some flutter waves in, let's see, 3 AVF. I would love to have another atrial electrogram.
Okay, well, I'd be happy to provide one for you. So here it is. This was the atrial electrogram performed on that patient. So are you in continued agreement with this, or no?
No, because I only see one atrial depolarization and then ventricular depolarization, except, oh wait.
Sure of that.
No, let's see. So I see 1, 2. Oh no, actually, I do see that there is 2-to-1 conduction, and then there's 1-to-1 and then 2-to-1 conduction at some point.
Well, it may be that some of
Or
these
it's just blocked.
What's that? I'm sorry.
Or some of the atrial.
Well, maybe that they're buried in the V's, right? At the very end of this tracing, I'll point it out over here. There is a gift that's been given to us.
Yeah, so there's definitely, we see 3 atrial depolarizations and then just 1 ventricular.
So what is the atrial rate?
Atrial rate here is 1, 2, 3, 4. It's 300 probably.
It's very fast. So interestingly, when the patient came back from the operating room, the anesthesiologist told us that with manipulation of the heart, the child went into what they described as SVT. And I asked the anesthesiologist, what was the heart rate in the SVT? And they responded 200 beats per minute. So if you had heard that story, what would you have thought was the likely etiology of the tachycardia? Do you agree that it would have been? So, you know, when most people say the words SVT, they're usually referring to either ORT or AVNRT. Do you think that a newborn in the operating room would have ORT or AVNRT at a rate of 200 beats per minute? What's a usual ORT or AVNRT rate in a newborn? when they
faster than that.
How fast usually?
I would say more than 250 probably at least.
Yeah, usually much more than 250, sometimes can be even 300 or even marginally exceed 300. So, so if they told you that there was tachycardia or SVT with a ventricular rate of 200, which I believe responded to just manipulating the heart. I think they said they just, sort of retouched the heart and it stopped. How would you in your mind's eye think about, we have no tracings, unfortunately, of that rhythm. What would you think might have been going on?
Could have been an atrial flutter too, I guess.
Exactly. It could have been an atrial flutter. So maybe it's not completely shocking that we're in atrial flutter a couple of hours later. All right, so you are, let me ask you this. Why do you think the patient went into atrial flutter? We were being paced. I didn't pull up, I have it, but I forgot to post it, the heart rate trend, and we were very solidly at 145 for a number of hours, and then it suddenly went up to this ventricular rate. Why do you think that could have happened?
And you said this patient was atrially paced, right?
Apaced at 145.
Yeah. Could it have been iatrogenic, meaning like you've caused it because of the atrial pacing?
Yes, and that's correct. How though? How would you imagine it might have happened?
If the atrial wire, if there was something wrong with the atrial wire, for example, or
And what exactly would be wrong? Lower threshold, higher threshold, bad sensing, oversensing, undersensing? What do you think could explain an iatrogenic? So when you're apacing, if you go into this type of rhythm, the likelihood is high that it is iatrogenic. So what would be a good explanation for why you might happen?
maybe undersensing?
Okay, I agree with that, but maybe you could expound upon that.
Well, if the wire is undersensing, it means that it can cause, depolarization at a point where the atria is still in some kind of refractory period, maybe, and that can cause an arrhythmia.
I think what you're trying to say is if you're undersensing, right, there can be an APC that's not sensed, and then if it paces at a critically timed interval from the last atrial event, it can induce flutter in the setting of a heart that's got a tendency towards flutter. So yeah, so this is usually related to undersensing. Okay, so now you're in this situation and you have made this diagnosis of atrial flutter. So I'm going to ask Dr. Barris, Dave, what would you do now? So patient is stable, by the way, has a reasonable blood pressure. Heart rate, as you see, is about 150 or so. How would you leave it like this? Would you not leave it like this? What would you do?
So I wouldn't want to leave it like that, but I think I could try to rapidly atrial pace over the flutter rate.
You could try to rapid atrial pace it, yeah. And how fast would you pace the atrium at to terminate this?
So if we're saying it's 150, if it was 2 to 1, then it would be just over 300. If it was, I guess 3 to 1, then it would be something above 450.
Well, I mean, you can determine exactly what the atrial rate is, right? Because you have the atrial electrogram, but it's particularly easy to see.
Right. So we saw there was 3 A's to each V, so it would be a 3 to 1. So that would be pretty fast. It would have to be above so it would have to be above 450 to atrial pace.
Well, I mean, what is the rate of the atrium there? How many
Let's see
boxes
here.
are between the two?
So I just see 1, 2, 3, 4.
Yeah, it's about 4 boxes, right?
So 60. Yeah.
So what does that make the rate?
So it'll be 60,000 divided by 160.
Mhm.
So would that be 375?
Yeah, that would make the atrial rate about 375.
So then we would have to pace above that. So it would be like 400.
Right. So when we discussed this case during one of our sign outs, Dr. Seiden asked me the question, why did you not try to APACE this patient? So we did not APACE him. We actually cardioverted this patient. And the reason that I chose to cardiovert the patient was because it can sometimes be very challenging to capture at that fast of a rate. You know, when the atrial flutter is at like a rate of 300, it's not that you can usually terminate it, but at 375, that means you're going to have to pace the atrium at like 400 beats per minute. And now, generally speaking, we think that newborns cannot have atrial fibrillation. So what if the patient were older and you paced somebody at at a rate of 400 beats per minute, there's a reasonably good chance you're going to induce a fib. Now, there are rare cases of babies who have a fib, and I was somewhat concerned that I was first of all concerned that it wouldn't work when you have to pace that fast, 400 beats per minute. I was also concerned that if it did capture, that we might induce a fib, and that might actually be even more unstable than this rhythm, right? Because then I don't know what the ventricular response rate is going to be. I don't know what's going to happen with that. So we elected to electrically cardiovert on the theory that that would be a more reliable result. Okay. Now, it happens that this patient's chest was open. Does that enter into your thoughts, David, on how you would do this, on your likelihood of success, et cetera?
I believe you'd be less likely to be able to cardioverter.
That's right. That's right. When there's air in the chest with an open chest, it can be very challenging to cardiovert somebody. So I asked that the ICU staff give a big dose of energy on the theory that the defibrillation or the cardioversion energy requirement would be much higher. So we actually gave 2 joules per kilo. We normally could give a half a joule per kilo. And would you synchronize this or not synchronize this?
Synchronize.
And what are you synchronizing to?
To the QRS.
To the QRS, exactly. And so this actually worked. So the patient was cardioverted with 2 joules per kilo back into junctional rhythm. And so then the patient was apaced again, and within 2 hours went back into atrial flutter again. So we then cardioverted a second time at like 4 or 5 in the morning, back into junctional rhythm. And now we're in junctional at about 115. So what would you do at that point, David? So you've now had 2 episodes of atrial flutter with apacing. And now you're at junctional at about 110 to 120 beats per minute after a second cardioversion.
I guess it depends on what the blood pressure was.
Yeah, so the blood pressure was 58 on 35.
So I would be very hesitant since I've already had 2 episodes.
Mm-hmm. That's exactly right. And that's what we were. We were also very hesitant. And so given that the patient was hemodynamically stable and the patient's, you could check the sensitivity on the pacemaker, but it was at its most sensitive setting. So even at the most sensitive setting, it was occasionally undersensing. which was likely the etiology of the iatrogenic atrial flutter. And so we elected to leave the patient in junctional rhythm in the high 100 and teens, and the patient was very stable and did well. And when the chest was closed, we asked that the surgeon place a new set of atrial wires, which they did. So the patient did very well. So this patient was managed very well by Dr. Kalis. Okay, so anyway, all in all, a good result. Any questions about this case? I thought it was interesting. Had a lot of different aspects to it.
Yes, Dr. Bass. So
Sure.
just going back to the open chest with the synchronized cardioversion. So would you always recommend like to go with the higher energy always?
Yeah,
Like,
yeah, I think so. Now, if that had, it would not have surprised me if it didn't work. If it had not worked, then I would have probably come in and tried a pace and but I would have probably let the surgeon know in advance because it could have potentially caused a problem. So, right, if I cannot cardiovert externally, then the only way to cardiovert the patient would be with internal paddles. And since I'm not a surgeon and I don't have access to that, I didn't want to get into that unless I knew the surgeon was either there or available. And I was a little concerned about the pacing idea. And when you pace that fast, I was first most concerned that it wouldn't work. But the second concern I had was simply that it might work, but it might actually put the patient into AFib. Now, a lot of people would say in a small infant, if you terminate the flutter and you go into fib, since babies have trouble maintaining atrial fibrillation, that it would probably resolve into sinus rhythm. And so that would be okay. That might have been true, but I wasn't sure if that happened. I wasn't sure how soon or how fast that was going to happen in. If it happened over a period of 5 seconds, no big deal. If, however, the patient was stuck in AFib for 10 minutes and was very unstable, and I could not externally cardiovert the patient, I was a little worried that I would be in a hemodynamically embarrassing situation, which is why I elected to try to externally cardiovert. So yes, you would always give a bigger dose. I remembered a case I learned this lesson about how air in the chest can make it very difficult to cardiovert somebody. Years ago, I was involved in an ICD implantation, and I was assisting a surgeon, and we could not cardiovert. At that time, we used to do so-called defibrillation threshold testing, which is that every single time we put an ICD in, we would induce VF and assess make sure that there was a minimum of a 10 joule safety margin between what was required to terminate tachycardia and what the maximal output of the device was. This was more important in the past because defibrillators did not routinely have what used to be called high energy. Today, almost all defibrillators routinely and from a standard perspective have higher energy. In Medtronic, the highest output is 36 joules. In Boston Scientific, it's over 40 joules. But those would have been considered quote unquote high energy devices in the past. And so we would not normally put those in patients unless they had we had some concern. And so we would fairly routinely induce VF and make sure that the device could detect and defibrillate. And we had a patient once after placement of a transvenous device where we tried to defibrillate the patient, and it would not work. The device tried 6 times to defibrillate. Of course, because we always have an external defibrillator on the patient during this form of testing, during those 6 attempts, we attempted 3 times externally. And finally, on the very last shock, we were able to terminate the VF that we had induced. And we were really, as you would imagine, it was quite dramatic, very unpleasant, a few minutes in the operating room. And then when we looked on fluoroscopy, we saw that the patient had a pneumothorax in the left chest. So had inadvertently developed a fairly large pneumothorax, which was probably why the cardioversion wasn't working. So very important when you have air around the heart, it may not, there was a very good chance that I would not have been successful in that case. But I felt like the worst that would happen is it would be unsuccessful, but nothing worse would happen. So Mahmoud, I think you have a question.
Yes. Is there a point that we would consider medical therapy in this case?
You mean to terminate the arrhythmia, or because of the arrhythmia after we terminate it to prevent?
To terminate.
Well, you could have used medication. Any medicines that you can think of?
I don't have something in particular, but I would think about something like a beta blocker, maybe sotalol.
Right. So remember that sotalol is really a class 3 agent. So it is a beta blocker, but it's also got potassium channel blocking effects in it. So we could have used IV sotalol, which has been touted recently in the literature as being an effective agent for conversion of things like atrial flutter. And the theoretical benefit is it's supposedly not much of a negative inotrope. And there are no reports of cardiovascular collapse as we would see with amiodarone. So that would have been one option. We actually now have that on formulary at Mount Sinai, although only Dr. Love and I are allowed to use it. So I would have had to come in, which was perfectly fine. I would have been more than happy to come in. But the downside of any medical therapy, though, is that it takes time. And when you have a post-op patient who is hemodynamically embarrassed following a major open heart surgery, you really want to get out of that arrhythmia as soon as possible. So I think your question is a good one. Could we have medically terminated this arrhythmia? Yes, I think that we absolutely could have. But I think that in this case, I didn't really want to leave the child in this rhythm for a very long period of time. So I think that now, if you read the literature, it seems like in the majority of cases where it's effective, IV sotalol will convert in about 30 to 60 minutes. So certainly wouldn't have been that long to wait. But I think in general, we are a little bit impatient when we're talking about a post-op patient. And so in this case, we just elected to cardiovert, but it wouldn't have been a bad idea to consider medical therapy. I think a more interesting question, or another interesting question maybe, is should we start something now, right? This patient now has had 3 episodes of atrial flutter, one presumably before surgery even started, and then 2 after surgery. In this particular case, I think I'm going to wait. We decided not to start any chronic antiarrhythmic therapy on the theory that every episode of flutter has really happened related to something either the surgeons or we did. In the surgeon's case, just touching the heart, and in our case, pacing the heart. So on the theory that less is more, I'm going to try to see if we can get away without any intervention at all for this.
Thank you.
Okay. Well, I have 1 or 2 more slides, but I think we'll stop here. We've been at it for a half hour. I hope you found this case interesting. I thought it was pretty interesting, had a lot of interesting aspects to it. And just to remind you, since it's Thanksgiving this week, unfortunately, we will not be having an angio review, as it will be Thanksgiving. I hope everybody has a great Thanksgiving, and we'll definitely be back with angio in December. Thanks, guys. Have a good day.
Thank you.
Be well.